thank you everybody for giving up an hour or so of your Thursday evening to attend the seminar. What I'll do is I'll explain what the seminar is about in two parts. The first part is on nutrition and dietetics and what that is, and part two is on insulin resistance and what my job entails and what I do in my current post. So hopefully interesting stuff. So the aims of today's seminar is to understand the role of an allied health professional within the NHS. It's to raise awareness of nutrition and dietetics. It's to highlight roles involved being a specialist dietitian within multidisciplinary teams within the NHS. My very own journey as a lead dietitian, formerly known as senior specialist dietitians. Just a trigger warning for the next hour or so, I think halfway in that second part, we will be talking about insulin resistance and weight management within the specialist weight management service. So if you feel a little bit uncomfortable with some of the advice or some of the things that will be mentioned, please do feel free to leave. Now, when we talk about weight management, I'm talking about those that are perhaps overweight or living with obesity. Often people think that we are supporting those that are malnourished or underweight, but it's the opposite end of the spectrum. Now, AHPs, so allied health professions, they're the third largest clinical workforce in health and care, and on the whole, degree level professionals autonomously practicing. There's 14 registerable titles. I'm one who's a registered dietitian, but there's physiotherapists that you might have heard of, occupational therapist, the speech and language therapist, paramedics and radiographers, to name a few. And you might have heard of these titles and those professionals as well. Now, out of the 14, 13 are regulated by the Health and Care Professions Council, also known as HCPC, and osteopaths are regulated by the General Osteopathic Council. So we provide, as an AHP, a care to assess, treat, diagnose, and discharge patients across social care, housing, education, and independent and voluntary sectors. The emphasis is on prevention and improvement of health and well-being to optimize individuals to live a full and active lives within their family and social networks, also within their education, their training, and workplace as well. So what are dietitians? Again, we're regulated by the HCPC. Dietitians are protected title by law. I guess you could say we're nutritionists who are legally able to work and advise and help treat those in the hospital environment, but that's not all where we work. Come on to that in the next few minutes, but the BDA is our British Dietetic Association, which is a professional association and our trade union, not to be confused with the British Dental Association. Now, let's not forget the GMC, that's the General Medical Council for doctors, and the Nursing Midwifery Council for nurses. You might be thinking, well, what are these, registrations? Basically, they set the standards for us. They can support us, and we're there to adhere to those standards. And there is audits being done as well with all registrations. You might be randomly selected. I did have a colleague who was selected twice in the space of 5 years, and it's just to demonstrate that you're up to date with modern practice, modern research, and you're providing that safe healthcare for individuals. We use up-to-date public health and scientific research to assess, diagnose, and treat, in particular, from a dietetic point of view, the nutritional issues for individuals and at a wider public health level. So can work in a variety of settings, like we've already explained, the NHS, in hospital settings, in the community settings as well, but also in the private sector, in sport, media, education, and the food industries as well. More and more of our dietetics courses, placements are being done in the private sector as well. So there's a big field there now. In the hospital environment, it could be an outpatient, so doing outpatient clinics, and that could be specialist areas, could be acute general wards, or it could be, again, specialist wards in a hospital environment, and again, home visits, so domiciliary visits as well. Now, MDT mentioned multidisciplinary team. That involves professionals from different fields. Again, it could be radiographers, physios, OTs, speech and language therapists, doctors, psychologists, all working together. I've got experience working in bariatric and weight management, and dietetics isn't just about weight management, there are other fields as well within this. So mental health, gastroenterology, renal oncology, nutrition, sports and pediatrics. There's plenty more as well. And within those fields, there are teams and we support one another. If, let's say, for example, a consultant in gastroenterology required specialist input from a dietitian to help an individual's IBS or Crohn's or any inflammatory disease involving the bowels, then they would get in touch with the dietitian. Again, if the patient's an inpatient waiting to be discharged but still needs support at home, occupational therapist may have involvement, or physiotherapist as well from a rehab point of view. So it's a multidisciplinary team. Now, in 2016, MP George Freeman, part of the Department of Health, welcomed a new legislation which allowed supplementary prescribing for dietitians, amongst other things, and that involves supporting consultants in the medical team with potentially prescribing. Now, I do have a few colleagues who have had a top-up course to be able to supply the prescribing support. However, I actually do not know what they've done with it, to be fair. And I'm going on to a course myself, fingers crossed, in the next few months. And that's to be looking into weight management and the big field of medications that is now becoming available. We've mentioned Orlistat, which GPs can prescribe to help those who are seeking weight loss. It's a lipase inhibitor, so it helps prevent 2/3 of the fats in your diet. But I think more importantly, and you might have come across in the news as well, or perhaps relatives, friends, exploring weight loss injections. Now, this is quite a sensitive area. NICE Guidance, which is our national authority, have been making recommendations for the NHS, and perhaps that door will be open because currently there's a lot of injections available for type 2 diabetes management, however, not yet licensed. And if so, not funded. There's a lot of trusts that are not funded and teams that are not funded to prescribe them. So it's a conversation I have almost on a daily. Had a couple of conversations today around it, and hopefully in the next few months we'll know more, and perhaps teams and departments will be funded adequately to be able to prescribe it on the NHS. I will be sharing contact details at the end, so do feel free to ask any questions. Looking at the model and process, and this can be found on the British Dietetic Association's website. We do have a model. On the top right, it's identifying that an individual may have a nutritional need. Not everybody does, but if there is a need, we assess. So if there's an issue, a challenge, a problem related to your nutrition and diet, then we'll assess. Perhaps they'll be referred on from GPs, from other healthcare professionals. What we'll do is we'll come up with a diagnosis. So we generate the past statement on the left, identifying the problem. You know, is there an inadequate nutritional intake? Is there, I mean, between all the specialities, there are so many problems that could come up. That's the first thing I'm thinking of. We try and figure out what the etiology is, what the reason is, what's secondary cause, what's initiated this problem, and we try and find the signs and symptoms to manage. We'll come up with strategies to combat this. Hopefully apply those strategies, the planning, the consent that we get from individuals. Are they ready to make those changes and implement them? And then we'll monitor and review them. We'll evaluate them and again offer that review and that support. We'll reassess if things are not going to plan. For example, in renal specialist, it could be that an individual is on a fluid restriction. Individuals might be watching their potassium and their phosphate intake. We'll have to source, you know, where the intake's coming from in their diet. Is their blood markers within ideal range, or if it's high or low, how do we help that nutritionally, medically as well from the doctor's point of view, and perhaps if there's any related issues with muscle mass as well. I often see physios working with us. So there's lots of specialities, lots of problems can be identified. It's how do we work with this and how do we improve their situation. Looking into my background in particular and how I suppose got to the post that I have, I guess I went the more roundabout long way. I did my undergrad in neuroscience with psychology many moons ago. So I think you're in a very exciting position right now. And that was up in Aberdeen, Scotland. And then I went on to do food science and nutrition a year after, a master's in that, because I realized during my undergrad, it wasn't what I wanted to do. A lot of people were going into doing PhD and a lot of research, but that just wasn't my calling. And I was always really into the fitness industry and nutrition. So before applying to dietetics, they told me that I'd have to get something that is related and perhaps meeting their criteria for application. So off I went to Edinburgh and did a food science nutrition course. Didn't realise I missed the deadline for dietetics, often with healthcare related registrable degrees, especially related to med school. The applications need to be put in, I believe, October, November time of the year before that you're hoping to apply onto. Do just double check the application and the processes and the courses deadline. So that was a big lesson that I learned. What did I do in the gap year that I had? I did a higher national certificate and got my level 2 in the registration of professions for exercise. So I did a course in health, fitness and exercise. Finally got onto my nutrition and dietetics course, and I graduated with a postgraduate diploma in 2017, went back to Aberdeen and then back to Edinburgh for that course. Then I graduated eventually, and my first job was as a renal dietitian in Dundee, and I did a little bit of weight management. I always knew I wanted to go into weight management, but a lot of the diabetes specialists were wanting me to actually apply for their positions. But I pursued. I thought, let's get some experience in the acute general wards. Let's get exposed to different specialities, because I think without that exposure, you might not get the skills that you'd hope to then flourish in another specialty. It's before you know what you want to do. You just want to explore the other fields, really. So that's what I did. I worked in general wards as an acute dietitian. I did that for about a year and a half, and then I realized, I've learned as much as I could. And again, I've been fortunate enough to have been involved in different teams, but I just knew I wanted to get down into the bariatric and weight management route. Now, bariatric is the weight loss surgical services. It's a tier 4 service. The weight management is divided into tiers. There's tiers 1 to 4, and 4 being the bariatric stage. Not everybody wants bariatric surgery, so if they require specialist input, that's the tier 3 stage, really. So tiers 1 and 2 is more community support. It's more health and well-being coaches that support you, perhaps not as specialist. What differentiates the specialist to tier 2 is that we do have access to pharmacists, there's nurses, consultants, psychologists. The wider team is available, something that tier 2s do not have. Now, became a band 6 specialist bariatric dietitian, which was great. Did that for 3 years, and then I progressed further. I actually went from a tier 4 position to a tier 3 services position. And that's where I am at the moment. SWIM stands for Specialist Weight Management Service. I've been doing this job for a year as a lead dietitian, and every day is a learning day. We just see so many different people from different backgrounds with different demands and challenges. In terms of continuing our careers, progressing, learning, there's webinars, there's opportunities for conferences, especially in the specialist area. So if it's something that you're pursuing, let's say, for example, physiotherapy or occupational therapy, you can specialize, and there's always training opportunities as well. I've done a bit of writing myself, a few videos and lectures as well. So lots of opportunities. Now, what do I do in my post? So got half an hour or so left. In our service, we're dealing with individuals that will meet the criteria, and that's the following. Anyone with a body mass index between 35 and 40 with comorbidities that is associated with obesity. Off the top of my head, I'm thinking type 2 diabetes, hyperlipidemia, so your cholesterol levels perhaps raised. It could be fatty liver disease, often osteoarthritis as well, certain breathing conditions. They all can be impacted by weight, blood pressure as well. So if you've got a diagnosis of other comorbidities, then you're meeting the criteria to be referred into the specialist weight management service. Now, we can reduce the BMI for those that are perhaps from a BAME background or ethnic minority background. I believe there is a title for that. So Caribbean background, perhaps South Asian backgrounds, you're at more risk of developing further comorbidities associated with obesity. So we can adjust the BMI and accept referrals that are those under that BMI 35. But if you're a BMI 40 and above, then you meet the criteria with or without any comorbidities. Now, the individuals that we see and what we deal with, what we support, are those that if your BMI over 35, we try and address insulin resistance. Now, if you're thinking about coming into either med school or dietetics, or if you're just curious about type 2 diabetes, then it's something that we try and address the symptoms of, or insulin resistance that can be also seen in those that have got pre-diabetes, address those symptoms that will hopefully have a knock-on impact on weight management, and then help those achieve their weight loss goals. So what we found statistically was if your BMI is over 35, you're at 66% chance of having insulin resistance. If you've got pre-diabetes, you're about 50% or more chance of having insulin resistance. Have insulin resistance if you've got type 2 diabetes. And for those that have got polycystic ovary syndrome, for women that do have that, 80% have insulin resistance, of which more than 80% are struggling with weight management. So there's a big population there that are struggling with weight management. Now, fatty liver disease as well, again, links between this and insulin resistance, that 50% chance of having that. For those that are actually struggling to lose weight beyond 3 months without restrictive measures as well, there may be suspicion of insulin resistance. So I'm going on about insulin resistance quite a lot, and we'll explain what that is in a little bit more detail, but rest assured, when we introduced service users into our service, we always say we don't start with those diagrams. Now, often they are given in tier 1, tier 2. The question I always ask is how relevant is it if you're struggling with insulin resistance? Because the Eat Well guide at the bottom there, 2016, was released. It was revised. It used to be known as the Eat Well plate. It's trying to depict what food groups you should have per mealtime, what sources of foods come from them. But again, there's quite a large proportion. I say large, a third of that plate is carbohydrate based. Now we'll touch on that in the next few slides. Also, calories in versus calories out. We hear that quite often. We hear it in the fitness industry as well. But is it as simple as that? Is it as simple as eat less, move more? Is it low fat this, fat free that, or is it low calorie this and that? If that was the case, we probably wouldn't be where we are today. It's a pandemic that we're living in with obesity. It's crossing boundaries, crossing continents. Statistically, it's rising. And it isn't as simple as that. It's quite an oversimplistic view of managing it, and it doesn't really take into account each individual's past medical history, their hormonal imbalances, etc., etc. So why are we looking into insulin resistance, and what is insulin? So when we eat, some of what we eat is turned into glucose. Glucose levels then rise as a result, and your blood glucose is your blood sugar. The pancreas then reacts, that's one of your organs, and it releases insulin. So it produces insulin, and insulin effectively pushes glucose into your body tissues. It wants to use the glucose as fuel, and that's what it's there for. That's what the glucose is there to help with. Now, every cell requires glucose, and we've got trillions of them. Blood glucose levels should then fall as a result of the insulin working. But insulin is also an anabolic hormone. So if you're ever on your search engine, you probably type in anabolic, you might get anabolic steroids coming afterwards. That's one of the suggestions. But what insulin does, it specializes in storing fat, and that's around your major organs, really. It's in the abdominal region. We did use other pictures in my service, someone with perhaps a beer-like belly, someone with quite a mass in their central area, and that's what insulin does. It does specialize in storing the energy that we accumulate that are surplus to our needs as fats. That's probably the most dangerous areas to be storing fat. So let's look into this a little bit more detail. So when your body cells become partially deaf to insulin, what happens is that blood glucose levels no longer fall in response to that healthy amount of insulin. So when we're dealing with individuals in our service, perhaps in their 40s or 50s, they would always say to us, look, 10 years ago, the amount of insulin my body was able to make was doing a great job. But over time, that resistance was building and increasing. So your body's then requiring more and more to just get the same job done that it once did. So the body does compensate, it shouts louder and louder, and it produces more insulin, and that's where the name comes from. Hyper, so increased amount of insulin, the hormone in your blood, emia, so hyperinsulinemia. Now we're talking about insulin resistance and hyperinsulinemia. What the side effects or the symptoms that we see do not help weight management. Some of the symptoms that a lot of our individuals in the service do experience is difficulty in losing weight, increased hunger or reduced satiety, cravings for carbohydrates and sweet foods, feeling sleepy after eating, fatigue, general tiredness, issues with concentration, brain fog, and other health issues possibly as well. I always ask how many of those, because individuals always ask us in the service, what am I doing here? I don't actually have type 2 diabetes. I've got weight loss goals. What is this? How is this relevant? But when we go through those symptoms, none of them actually help with your weight loss. It makes it a lot more difficult. Insulin resistance is a spectrum. It's a scale. It's in 3 phases. The compensatory phase, where you've got raised insulin levels and a healthy blood glucose levels. That's brilliant. Then you've got the pre-diabetes range, which may occur after prolonged, let's say, exposure to carbohydrate intake. And that might be 3 to 8 years' time where you might be going into the pre-diabetes range. And that's when you've got raised insulin and raised blood glucose levels. And then there's the third phase where it's type 2 diabetes is diagnosed. And that's when you've had initially raised insulin, but high blood glucose levels, and you need further support, not just lifestyle, but perhaps medicinal as well. Now, the body's equipped to actually cope with the demands of releasing insulin for quite a number of years. It could do that for 5 years or so, and it could produce it at 5 to 7 times the rate that it would normally. But again, it's got a limit before your blood sugar levels are no longer dropping, and you could check them out in tests. Often GPs do tests, and if they're concerned, they might do more frequent tests just to see what those levels are like. And if it's not moving, then they'll have to take perhaps medical or potentially surgical interventions. That's where we come in as a specialist weight management service. We're here to support, to give advice, and we provide 12 months care. And again, we're a multidisciplinary team. Individuals have access to the whole team if they require it: consultant, psychologist, the physios, dietitians, and support workers for weekly monitoring. What can we do about it? Again, we can manage stress, we can manage sleep, we could do resistance-based strength exercises, but as a dietitian, we look at the nutrition. We look at the following ways of eating. We don't want to call this a diet. Some patients do ask us, so what diet am I following? We want to see it as a more sustainable, different way of eating that perhaps can be incorporated in your lifestyle for a prolonged, long period of time. Now, we look at lower carbohydrate eating, intermittent fasting, also known as time-restricted eating, acetic acid, so that's found in all vinegars, but there's some research behind the apple cider vinegar supplements, lowering your glycemic index eating, so that's low GI eating, you might have heard that, or looking into a very low-calorie diet with or without partial meal replacement products, and that's for short term if we've exhausted the menu of options that we've just provided. So some people might want to do 1 or 2 things, others might want to try all 4, others might just want to work towards, achieving some of those ways of eating that will hopefully help their insulin resistance, but also their weight as well. Now, there's a lot of research behind lower carbohydrate eating and intermittent fasting that has been backed up by science and evidence to support with insulin resistance. Some limited research behind apple cider vinegar supplementation. We always say you can try it and see how you do. Everyone reacts differently, and plenty of research behind lower glycemic index eating. So let's look at them in a bit more detail. Lower carbohydrate eating. So, well, what is it? Carbs are our primary go-to fuel. Now, carbohydrates include sugar. You might notice them in some food labels. This is what it does to our blood sugar levels. It causes it to go up. Insulin then gets released because it detects the sugars rising, and it helps to get rid of the sugars out of the blood into out of the gastric systems into the tissues for us to use. Fats and proteins are also what we class as macronutrients, but the amount of insulin that is required to process fats and alcohol is none. You need a little bit for protein, but almost twice as much, if not a little bit more, is required to process carbs. So we're demanding more from the pancreas to release insulin before ingesting carbohydrates. Now, Protein is great for a number of things. Again, if you're one that engages in a lot of physical activity, you might have heard the protein shake supplements. That's to supplement your diet. It's great to help you recover, to heal, but it's also really good to suppress appetite as well. They're really filling. I always say if you fill the table with, plenty of carbs, could be bread, could be potatoes, rice, pasta, we might be able to get through 3/4 of that table. But if you were to put lean cuts of meat, proteins, beans, pulses, eggs, then it's a lot more trickier to get through. You might get through only a third, if that. So primary go-to fuel is the carbohydrates. There's some of the examples I've just mentioned, but also noodles, couscous, breakfast cereals. You've got sugary foods, snacks like crisps, cereal bars, and drinks. Don't forget your Coca-Colas and Lucozade. They're all quite rich in carbohydrates. So we advise limiting your carbohydrates to perhaps once a day, maybe avoiding them if you're snacking. So to find alternative snacks. Start off reducing carbohydrates. If you're one for counting, we encourage those to aim no more than 130 grams, but we don't say that straight away. What we're finding in the Northeast is perhaps our carbohydrate intake's close to 300 grams. So to expect anybody to reduce it overnight, it's unsustainable. So we say wean yourself off carbohydrates and gradually reduce them and replace them. That's important. Replace them with proteins, replace them with fiber. Those that do not prompt a higher amount of insulin to be released to process. Plus, they are very filling and they're very beneficial. Intermittent fasting, also known as time-restricted eating, what we encourage is to extend the period that we're in the fasting state. Diabetes UK advocate this to help improve insulin resistance, but we do advise for those that are perhaps on medications other than metformin to always get in touch with us. We'll check the bloods and we'll taper a specific way of eating for individuals to monitor them closely. We don't want the erratic changes in the bloods if they're already diagnosed with type 2, because they're a lot more sensitive to some of these changes. Now, we're in the fed state for about 3 to 6 hours after eating, but if we were to not eat beyond that period, it could be up to 72 hours after eating that we go into the fasting state. Now, anything beyond that, so 48 to 72 hours, we're entering the starvation state. There's an old myth where sometimes it's said that you have to eat little and often to lose weight, or you must eat breakfast to lose weight. It's not quite true. It's false if you're struggling with insulin resistance. We actually want you to extend that period of fasting just to allow your body to chip away at the fat reserves that we do carry and to help manage those insulin resistance that you might have and the symptoms that you might be experiencing. So there are regular cycles of being in the fed and fasting states. For example, if you start off the day and you're wanting to lose weight, you start off the day eating breakfast at 6 a.m. and then a snack mid-morning, go to work, have lunch, a mid-afternoon snack again, come home, have an evening meal, and then a supper before you go to bed at, let's say, 9 p.m. You're constantly in that fed state. You're not allowing your body to go into that fasting state. And we ultimately want to extend that. Although we're seeing, I believe 2/3 of the individuals in our service are saying we don't actually have time for breakfast. So they're naturally in that intermittent fasting practice and they're eating 12 p.m. and finishing 8 p.m. So it's something that, that I think people are naturally doing just because of the time pressures that they're in. Now, this advice is going to be different for those perhaps are within an ideal weight range. So this is specific to those with diabetes or weight management goals. Now, there are different forms. There's daily, weekly, periodic forms. The periodic forms are more extended periods of fasting. I did have a patient actually tell me that they were doing 28 days fasting, just pure fast, just fluids, which wasn't safe or something that we wouldn't recommend. There's lack of research, if any, to advocate that. The person wasn't even having any vitamins or minerals over the counter, so that was a concern. And when I asked the gentleman, how long did you plan to do this for? And they said 40 days. So it was a little bit of a concern for us. So I managed to reintroduce some calories, some good macronutrients, check bloods, provided some supplementary advice, and things are settled and he's improving. His weight loss has slowed down. That's one thing as well. People get attracted to that weight loss and that sudden rapid weight loss that we want yesterday, don't we? But it's to slow things down really and help manage that. There are risks of having gallstones to be forming gallstones if you experience any rapid weight loss. I won't bore you with that, but that's a concern that we had with this gentleman. The time restricted eating and the research behind is the 16-8 approach. That's 16 hours fasting and 8-hour window of eating. Sounds quite extreme, but if you're sleeping, you're lucky to sleep 8 hours, then you've got 8 hours of the rest of your day to fast. That could be 4 hours in the morning, 4 hours in the evening. And when we say fasting, you are in the fasting state, even if you're having sugar-free fluids, which don't activate that cycle of your blood sugars going up and down. So sugar-free fluids we do encourage. Could be, if you want to have fizzy pop in the morning, that's fine, as long as it's sugar-free. Tea, coffee, if it's black, great, or water. So maintaining hydration is always encouraged. Just being conscious of time. Apple cider vinegar. Some of the paperwork that we've come across recommend taking 20 mils of apple cider vinegar, the liquid form, and dissolving it in a small glass of water. And you could try them just before your meal times. And what that essentially does, it helps line the stomach. Supposedly it helps line the stomach, and what it does, it prevents the spikes in your sugar levels. So it coats the stomach quite nicely. When you're introduced to nutrition, what happens is that it rises the blood sugar levels a little bit slowly, almost like the impact that proteins or perhaps fiber would have. It acts as a coating. For example, if you would go to a restaurant, often you might find a bread first thing on the plate before you even ordered. And what they want to do is activate that carb cycle, so you're feeling the elevated levels of sugar and you crave that. So the symptoms that you might experience, the craving, it switches on, and you end up maybe ordering more and more than you would have. If you were to start a meal with protein or like a salad dressing or fiber, you're not really releasing that insulin. You're not getting the same effects as you would. So something to think about if you're considering to lose weight. A lot of people cannot stomach the apple cider vinegar, especially in liquid form. I've tried it. It can make you nauseous, and it is vinegar at the end of the day, not the most pleasant to drink. So you can use a straw. That's what we suggest, or you could use the tablet form. Now, very limited research into the tablet form or the capsule form. So what we suggested was the 20 mils equivalent in the tablet form is 1,000 milligram dose. So consider taking that 5 to 15 minutes before a meal time. The reason why it's 5 to 15 minutes, just to allow your body to break down that tablet to get the effects of the apple cider vinegar. Now, my mother-in-law used to use apple cider vinegar for reflux purposes, because what it does, it constricts the valves on the upper and the bottom end of the stomach, and it prevents the gastric juices from going back into the food pipe or the respiratory pipe. So it's something that she uses. You might know some people that take apple cider vinegar first thing in the morning, but from a weight management point of view, especially from an insulin resistant point of view, it's worth giving a go before your meal times. It's something that we encourage, but again, it's not for everybody. It helps to manage your glycemic balance and insulin control. You might have come across the mother in it. The mother is the sediment. It's a probiotic that has some benefits on the gut, or so-called, but it can look a little bit gross. So some people would have it without the mother. Lower GI eating. So basically we've got a scale for carbohydrates, fast acting sugar on one end and slow releasing energy on the other. What lowering your GI eating means is having more of the ones that release energy a little bit slowly. So not only can that slow down that spike in insulin and the blood sugars, but also help you keep you full for a little bit longer and reap the rewards from the energy that you're breaking down over time. So it might prevent snacking, for example. So baby or new potatoes, sweet potatoes instead of a jacket potato. If you must have a jacket potato, it's thinking about keeping the skin on, and that's the effects of the fiber that would have on insulin resistance. It's thinking about whole grain, wholemeal sourdough instead of white varieties. Oat, again, if you're having breakfast with carbohydrates in them, it's oat-based high fiber cereals like porridge or natural muesli instead of cornflakes, Cocoa Pops, your Rice Krispies, etc. So it's thinking about swapping out the carbs that you're having for a healthier type of carbs. Now, there was a twin cycle hypothesis made in 2007 by Professor Roy Taylor, and he essentially said, in simple words, that type 2 diabetes, when he was looking into type 2 diabetes, it was essentially linked with insulin resistance. And we know insulin resistance linked to visceral fat, so central adiposity, so fats around your organs, your major organs. But we haven't really found a way to spot reduce the fat. We can't just say, I'm going to lose fat, I'm going to go on a diet, I'm going to do this particular exercise, I'm going to lose fat around my abdominal region, my belly. So what they developed or devised was an 800 calorie diet. So it's the very low calorie diet. And we advise this with caution. For those that are on medication other than metformin, we have to closely monitor their bloods, their health, any side effects. For those that perhaps have got a poor relationship with their diet as well, or perhaps not mentally stable, and it's just looking into this a little bit more detail, whether or not it's appropriate. Some psychologists in our team have said certain individuals may not benefit from this. It may backfire, or it may trigger or rehash past experiences. So again, it's not for everybody. It's very restrictive and it's very prescriptive as well. We recommend up to 12 weeks maximum. Again, risk of gallstones with very low calorie diets. We also recommend A to Z multivitamins and minerals that you can supplement with over the counter. So getting them from your local supermarket. And again, it's following this quite strictly. Again, some people might, to begin with, try it once or twice a week. Others may only try it for 2-3 weeks. Some people requiring short-term weight loss for achieving a certain healthy weight for operations. It can be a knee replacement, hip replacement, breast reduction. Some people need to lose weight really quick because they've got a date in mind. And it's thinking, look, is this appropriate? Is this feasible? Can I engage with a very low calorie diet? And it is following a plan. However, it's the most effective way of improving insulin resistance. In 2017, there was the direct diabetes study. The trial was done, and I believe over half the participants went into remission. The study was then was continued from 2020 to 2023, and of which I believe 11 out of the 48 that went into remission were still in type 2 diabetes remission, which is great. That's reversing, not quite reversing, but bringing the blood sugar levels down and perhaps coming off the medication. So some strong benefits, especially from an insulin resistance and type 2 point of view, but also looking statistically at the weight loss. Again, larger weight loss found in those that were in the trial versus those that were in the placebo control group. So some really strong benefits there. So that's the advice that we offer. Thank you all for listening.